Hello and welcome back. It has been a while since my last video. I just started my attending job recently, and so I've been preparing a lot of these resources for myself for my surgeries, and it's just a lot of fine-tuning to get it up to snuff in order to present. So today we'll talk about radical hysterectomies in the context of cervical cancer. So let's first talk by saying what is radical, or what's the definition of a radical surgery. And so a radical surgery to treat cancer involves removing the tumor along with surrounding tissue and structures that could potentially involve cancer. And so today we're going to be talking about a radical hysterectomy. You can see this picture here of the uterus, and the radicality of this surgery is removing the perimetrium, some of the vagina, and then the uterosacral ligaments, which are coming off here as well. And so it includes the surrounding tissue of the area. So before we get into the classifications of radical hysterectomy, I just wanted to make this point here because this I see is sometimes taught wrong. An extrafascial hysterectomy is a simple hysterectomy. I think sometimes, or this gets passed down that it's confusing, but extrafascial is just a simple hysterectomy. So it's really the more common hysterectomy that we do. Removes the uterus and cervix. We're not taking any extra tissue, no perimetrium or extra vagina. Okay, so this is the classification system that we use now. It is a it's an updated classification system from the Piver-Rutledge-Smith classifications. And this is what's on NCCN guidelines, this exact chart. It actually includes type A, B, C, and D, and there are some subcategories. Type D, I don't have here. It includes ultra-radical procedures, less common. We're not going to be going over those. So if you are interested in reading about them, you go for it. This lecture is going to be focused on this type C1 radical hysterectomy. We will not be talking about shape, conserve, any of those trials in this. This is specifically for the surgical steps of doing a radical hysterectomy. If you do have questions, though, feel free to leave them in the comments and I can answer them. Okay, we can't start talking about a radical hysterectomy until we talk about and know, like the back of our hands, the spaces of the pelvis. So we have the two bilateral spaces, pararectal, paravesical spaces, which we open quite frequently in even our endometrial cancer cases. And then these unilateral spaces, the prevesical space, rectovaginal, and then retrorectal or presacral space. So let's look at this picture here. I have a lot of pictures in this presentation. I don't own any of them. I tried to give credit wherever I took the pictures from on the slides or at the end of the presentation. And so let's look at this. This is the left pelvis. Here's your external iliac vein, so that you know that the artery will also be coming probably a little bit more superficial than this. Also, your internal iliac artery giving off your uterine, and then going to be giving off your obliterated umbilical superior vesical artery. Now, I like this picture because it's a really, really nice picture of the anatomy here. What I don't love about this picture, though, is this paravesical space actually encompasses this area here. So you do have this paravesical space here, but the space that we're opening for our lymph nodes is actually here, paravesical space. And so I wish this kind of came all the way out to here to incorporate this area. We're actually not dissecting for our lymph nodes in this space, but you can open this space here, obviously, and then we open this space here quite frequently. And then here's your left pararectal space, your ureter being one of the borders here. Okay, so back to our hyst. So your patient is all prepped and ready. You're getting ready to make your incision. Some people will do a fan and stale incision. I prefer vertical midline just for the space. So it really is physician preference and what you feel like you would need. And then the first thing that you want to do when you've entered is evaluate for any metastatic disease, because if you see disease in the pelvis, radical hysterectomy is most likely not the correct treatment. And so you want to take a feel around, you want to take a good look around, be sure you don't see any evidence of metastatic disease. If you're concerned, you do want to send a biopsy, frozen section to rule that out. Once once that's ruled out, or if you don't see anything, then you'll pack the bowel if you haven't done that already for visualization. And then you can start like a normal hysterectomy. So putting Kelly's on the cornua, not exactly in this picture here, unless this might be a Kelly. And you can start with your round ligament. This is also physician preference. Some people will Bovie, some people will stitch. I personally like to put a stitch in the round to retract it open, but it is really whatever you'd like. So here is demonstrating, well, obviously this is even in a simple hysterectomy, so we'll go over that as we're going over a simple hyst too. You should know these steps already, but going through your round ligament here, and then opening to the broad, the anterior and posterior leaf of the broad. So once we have our round, we'll say we ligated our round ligament right here. Let me see, can I draw on there? Right here. This is open, and then you're going to open the retroperitoneal, the posterior leaf of the broad, parallel to the IP. We need to get into this space in order to get our uterine laterally. Here is another picture here. These are laparoscopic pictures. They're actually they're the best pictures that I could find, essentially. But once again, your round ligament is here. You have already opened it. Maybe you opened it a little bit more lateral. And then you're going to continue the posterior leaf of the broad, opening it parallel to your IP. Your next step is to find the ureter. Whenever you're doing any kind of surgery, you always want to know what can be damaged. And when we're dissecting in the retroperitoneum, the ureter is one of the number one things. So this is on the right side. So you have your right external iliac vein here, where it's being pointed out. This is also laparoscopic. And your right ureter right here. So when you've opened, I don't see an IP, so they probably already took the ovary up here. But when you're opening the retroperitoneum, you're pulling this posterior leaf medially, and your ureter is going to lie on the posterior leaf of the broad ligament, like it's saying here. Just another picture here. So external iliac artery, internal iliac artery, so common splitting. The bifurcation of the common iliac into the internal and external is where you should be able to find the ureter. So it should cross at this bifurcation. So if you're ever not able to find the ureter on this medial leaf, say you opened, you're looking all around, come cephalad. You can always come cephalad and try to find where the ureter crosses over the bifurcation of the common. Okay, next is opening the spaces. You found your ureter, or maybe you want to open the spaces and then find your ureter. Either way, it's probably preference, or maybe there's a right way to do it, but regardless, you're going to open your paravesical space, your pararectal space. You need to get those spaces wide open. If you're doing a lymph node dissection, which you most likely are if you're doing a radical hysterectomy for cervical cancer, and then also in order to ligate your uterine out laterally at its origin. At this point, you may want to complete your pelvic lymph node dissection, sentinel versus full. Some people do leave it towards the end. I have another video on pelvic lymph node dissections, including the borders and periaortic lymph node dissection. So check that one out if you're wanting to go over it, because we won't be going over it in this video. So once we have our spaces open, we have identified the ureter. Maybe you did your lymph node dissection. The goal now is to dissect off the ureter, take the uterine, follow that ureter down, and we have a really nice picture on the next slide. Unroofing the ureter, taking those bladder pillars and the parametrial tissue, mobilizing the bladder off of the uterus and the vagina, and then we'll go along the posterior, get our uterosacral ligaments, and then making sure we get a margin of the vagina. Let's get into it. Okay, so you must know the course of the ureter in any pelvic surgery, but extremely important here, following the ureter down. you're going to, this is a really, really nice picture, again, of the uterine. So identifying your ureter, coming under here and isolating the uterine artery at its origin off of the internal. And then I have a nice picture on this next page too. This will facilitate the dissection of the parametrium. Okay, so this is on the right side of the pelvis. Here you have your common, this is your ureter. Here you have your common iliac splitting into the external and then the internal. And then you have your uterine artery going horizontal to the uterus. Following this, your obliterated umbilical, which gives up the superior vesical artery. If you have the anatomy that looks very nicely like this and you can identify the uterine artery, that's great. Otherwise, you can find the superior vesical artery. You should have found it because you opened the spaces, you know what the paravesical space is, and you can follow that down to where the uterine artery is. So that's also a really nice way to find it in any case if you do need to go out into the retro and get your uterine artery, even in a non-radical hysterectomy or non-planned radical hysterectomy. And then you're going to want to ligate this at its origin. So where this picture is showing is clearly not at the origin, but imagine that these moved over. So you want to get a right angle or some kind of dissector underneath the uterine, create your window. You can use some ties. I've seen people tie and clip. And then if you tie both sides, you can leave a tie on this end in order to retract it medially to help you get your parametrial tissue, which is going to be in this area here. This is another picture here of isolating the uterine artery. I think the more pictures you can see, the better. The more cases that you can see, the better. Again, we have our common splitting into our external iliac, external and internal iliac arteries. You have your ureter here being retracted. We have our spaces open. So this is a perfect picture. And then in this picture, they've already ligated the uterine, and they're giving upward traction on this uterine artery. So that, it is showing us that the uterine vein here as well. There's sometimes a ureteral branch of the uterine artery that needs to be clamped in this area. And other than that, yes, this is just a really nice photo of what the dissection would look like. You're going to continue dissecting out the ureter, which will continue to go through here. And as you can see in this space, you're going to continue to reflect that uterine artery medially so that you can get all this tissue here unroofed from the ureter. And this is just another view of how close the ureter is to the uterine. I apologize, it's a little bit blurry. But essentially, you're taking this lateral here and then you're flipping it medially to get all of this parametrial tissue that is on top of the ureter. I would say one more picture, but I'm pretty sure I have a couple more. I don't ever know what picture is going to resonate with you. Maybe you don't understand what's going on in the first picture. 5 pictures later, you're going to get it. And so I have a star here where this ureter is coming in. I think it's just orienting yourself to all the different ways that we see, a picture is really hard to capture anatomy. I think we learn that in medical school, and then you go into the OR and you're like, this looks nothing like a textbook. So the more pictures you can see, truly, the better. So here is your ureter coming down. Here's your uterine here. This is a really, really nice picture. And we're going to be, I guess they're saying that this is the internal here. But this is just how another view of how the course of the ureter. Okay, so moving on from the uterine artery, here, this picture is showing your hypogastric or your internal iliac artery giving off your uterine, which is already tied off. The string is left here. You're thinking that we're going to be pulling it medial this way. This says uterine artery and tunnel. You can kind of see where it is. And we're getting to the point on the entrance of the ureter into the ureteric tunnel. And so it's really important at this point that you're dissecting the bladder down, you're retracting the bladder down. Potentially you already took some of that peritoneum down and you're reflecting the bladder back. And then you're pulling cephalad tension on the uterus with those Kelly clamps that we placed in the beginning. Tension is going to be really key here to assist you in opening that space so that you can get under here to unroof the ureter. And so once you've exposed this space, you're going to take your right angle clamp and get under and spread underneath this ligament, spreading your right angle and not closing it, spreading and coming out, spreading and coming out. And typically you have to come, from either direction. So you're going to come and go in a cephalad direction, and then you're going to come from a caudad direction, making pedicles for yourself to then take this parametrial tissue up medial with your specimen. And so this is another view of exactly what we were talking about, where the ureter enters that ureteric tunnel, and we're getting these bladder pillars, which are going to come with our specimen as parametrial tissue. And so here's your ureter entering this tunnel here, just like in our last picture. And this is that vesco-uterine ligament that we want to clear off, essentially to the point of the ureter's insertion into the bladder. And so if you follow the ureter here into this picture and then go to picture B, you can see all of the tissue that is reflected medially towards the uterus to leave this ureter down here with just the insertion into the bladder. And so it's very vascular in this area. As you can see, this is a really nice picture. There are a lot of important structures and vascularity in here. So it's really important where you're going to do a lot of dissecting and then clamping with right angles in this area. There are actually a lot of really nice YouTube videos that I'll put at the end that show this move here, because I do think you have to, you can't actually, I can't explain it to you. You have to see it being done. A step that can be really helpful even before you take your bladder pillars down is we talked about retracting the bladder. And so this is the best picture that I could find to demonstrate this. Maybe I'll try to draw it at some point, but this is your cervix. I'm assuming let's just say that it's ending right here. Your bladder is back here and this is your vagina. So you're going to try to get your bladder all the way down. If you can, and I guess didn't necessarily go through the portion where you take the bladder peritoneum down and try to get the bladder back, but that's a step that probably falls somewhere after getting your uterine and dissecting your ureter down. And when you hit those bladder pillars, it's really nice to have your bladder already dissected down so that you can kind of aim towards the area. So you're getting those bladder pillars, you're lateralizing your ureter to try to get the insertion into the bladder away from your vagina. But if you can use a sponge stick or something to measure how much of the vagina you need to get, and you can make a little bovie mark there, aiming a point that you can aim at, I find it to be very helpful. And so once you have your bladder pillars down, you may need to do a little bit more dissection of the bladder off of the vagina in order to get your 1/3 to 1/4 vaginal margin for this type C radical hysterectomy. Okay, so we're almost there. So next is to develop the rectovaginal space in order to divide the uterosacral ligaments. And so this is a nice photo here. Your rectovaginal space is here. And then on this picture, it's going to be right in this area. And so there is a layer of peritoneum over this space, and that we typically are pulling out and incising into. You want to be sure that you're not incising into the rectum. You're trying to preserve this vagina because you're going to end up taking, the upper 1/3, 1/4 of the vagina. And so this is a nice picture demonstrating, this is from a cadaver, but the rectovaginal space, which is here, here's your uterus with your uterosacral ligaments. Here's your rectum down here. And so opening this space isolates the rectal wall. You can identify the posterior vaginal wall, and then you can define the limit of where you want to take your uterosacral ligaments, at least 2 centimeters from the cervix in this type of hysterectomy. And then it also can facilitate finding the hypogastric nerve, which I have a picture of coming in here. And so you're going to divide your uterosacral ligaments, and then you'll be ready to take your specimen. And so when you're ready, you're going to come across the vagina with highly curved clamps at the level that you deemed 1/3 to 1/4 of the vagina. And then your specimen should look like this. So you have this parametrial tissue lateral. Here's your uterine that you took off, that you were retracting medially here. And then your 1/3, 1/4 of your vaginal margin. And so it kind of retracts once you have it off of tension. But this is a really nice specimen here, which yours will look exactly like that. This is something that I found in one of the papers that I'll cite at the end, which just shows the some of the important things to put in an op note. So I kind of put this in here for myself, but maybe some people will find it helpful as well. And then here are a couple of my references. Honestly, there are a lot of good GYN and gynonc texts that describe radical hysterectomies. I think the more you can expose yourself, the better. People have different techniques, different ways of approaching it. Next is my YouTube surgical video recommendations. This one is really good. They do like a picture in picture, and the smaller one, unfortunately, is the better one. It honestly is the one that should be big, but it is very good, I think, on steps of an open hyst. And hopefully the goal will be that I can make these in the future, but I'm not quite there yet. So stay tuned. Please leave any questions or comments in the comment box below. I would love to hear what was clear, what wasn't, what you liked, what you didn't like. Yeah, so I hope you enjoyed it. This took me a very long time to make, but I mainly made it for myself because I think that it is really great anatomy. It is a really, really great surgery that we do with some technical parts. So I hope you enjoyed it as much as I enjoyed making it. Take care.